Hi, everyone. My name is Ashley Houck. I go by she, her pronouns, and I'm a physical therapist here at Flyspace PT. So welcome to the info session, as well as the Q&A. It is titled, I think I have scoliosis, now what? So before we begin, I think I've worked out all the technological glitches here, and hopefully y'all can see my screen and presentation. And oh, I knew this was going to happen. One moment, I'm actually going to backtrack. So I lied. There we are. Okay. So I think this should work now. Before we get started, all of us here at FlySpace rather, are committed to diversity, equity, inclusion, and belonging, especially as it pertains to anti-racism and allyship. So with our interactions amongst one another, with our patients, and especially during outreach and education, we do find it important to let others know and reiterate this mission and values that we have with our commitment. Our mission is to strive to create transformative and safe space for BIPOC folks and the LGBTQ plus community where anti-racism is at the forefront of our care. In the realms of healthcare and the performing arts communities, we do hope to see consistent representation of BIPOC folks and LGBTQ plus communities through clinical, educational spheres, and external facing materials for all to feel welcome, seen, and heard. Our values include believing and embracing and embodying loyalty and justice in our interactions with one another, with patients, and throughout the performing arts communities. So thank you so much for letting me share these with you all. And we will get started here with the material. I try to keep this in question format to go with a theme. What is scoliosis is the topic we'll be covering first. How do we detect it? And what is the scoliosis PT specific treatment? And what does that look like? So to begin, I packed a question within a question. What is scoliosis? I think it's also important to note, what is the cause? Interestingly enough, we don't know. The evidence-based medicine that's out there is really broad, and that is a wonderful thing. It is still known, unfortunately, that it's idiopathic. A lot of times you'll see that term idiopathic scoliosis, and that simply means that that's an unknown origin. It is multifactorial. That is what we do know. And while I won't get into the details of those contributing factors, they can broadly include someone's genetics. So if our family members have it, we may be more predisposed to getting it as well. There is a correlation between hypermobility, which is extra joint mobility throughout our body, and scoliosis. There are some types of scoliosis that are congenital, so we're born with it at birth, and it's neuromuscular in nature. So spina bifida, cerebral palsy are examples. And interestingly enough, it only affects about 3% of the population who are otherwise healthy. That still can be a pretty large number too when we think about the diagnosis itself. So I just want to sort of introduce this sense of not knowing exactly what is the cause for our scoliosis that we see in individuals. The other really important piece then is classifying scoliosis. I do hear sometimes folks get confused with what scoliosis is. And so we're going to classify into two types. The first is structural. This is what we're more familiar with and seeing. And when I first learned about scoliosis, the way I would remember this structural type is to think of a building. The groundwork and the framework is typically very solid, and our bones in our body as well are rather firm in structure and aren't quite malleable like our muscles and our soft tissue. So the bones comprising of our spine, I have a little picture here to the left. They are not malleable in nature, and they will drive the three-dimensional curve that we end up seeing on our x-rays. The bone shape, even though in this picture on the left, in the two-dimensional form, it looks like a square, but really they're cylindrical, those bodies of our vertebrae. And they do change. Again, we're not sure why, but they do change in shape. They may form a wedge, so they can end up being shorter on one side and larger on the other. And that kind of conformation and change in those vertebral bodies will then form that rotation that we see. It can be the S curve on our radiograph or X-ray, or it can be the C curve as well, but it is a change in the actual bone structure. Adolescent idiopathic scoliosis is AIS. It is the common form of structural scoliosis, and it's usually detected in the first growth spurt just before puberty starts. And it is generally benign, meaning it's pretty silent. We don't often find that at that age, right before puberty, that age group is complaining of symptoms, which is a good thing, but also in some ways it's tricky because if we're not feeling anything, we might not be detecting it in the time frame that would be most beneficial. So the curvature that we end up seeing on the X-ray can either decrease, it can stay constant, or it can increase. And we may not have any pain or symptoms with that. We often find that age group that's diagnosed in the adolescent age range does not have symptoms. That doesn't go across the board for everybody, though. So I feel that Rigo is someone who actually founded the method where I was certified for scoliosis specific treatment, really defined it well. He kind of wrapped up the cause and the definition all in one for structural scoliosis. So it's a complex three-dimensional deformity of the spine and trunk, which appears in apparently healthy children and can progress in relation to multiple factors during any rapid period of growth or even later in life. I do find that when we use the word deformity, we have to be very careful. I try to be very intentional with the words that I use in defining this because we do educate, which I'll explain in a few slides, our patients a lot about their anatomy. And I try to just say that there's a change in the shape versus a deformity. That's a word that I try to shy away from. So now the other category is non-structural. This is something that can be driven by muscle asymmetry, length or strength, a leg length difference, which can be functional as well. It doesn't mean there's a bony change. That's the big defining factor here. There is no bony change, thankfully, and a postural difference or decreased postural control can make it seem like we have a change in our spine structure, but really it's soft tissue based. So again, to reiterate, there's no bony or structural change, and physical therapy treatment can be very effective, and it might not need to be scoliosis specific in this instance. So some folks will go to the doctor and they'll say, oh, I see a scoliosis here. It's not truly a structural scoliosis. Therefore, we can really change and achieve the goals, at least, that that person wants to meet without that sort of overlying concern of it being a bony change in our body. So those are two different types. And I really think it's important for us to be sure that we have one versus the other and know the differences too. So moving on here, we are going to talk about how do we detect scoliosis. When I was growing up in elementary school, I distinctly remember getting in line, and sometimes by height, I don't know why, but we would go down to the nurse's office and she would have us simply bend forward. That is listed here on the slide as forward Adams bend test. The nurse of the school or the teachers even sometimes are just briefly instructed as to what to look for. And practitioners such as nurses, doctors, physical therapists will be able to look at that with a more nuanced lens potentially than somebody who is just quickly trained. But it's still a very effective screening tool to say, okay, this individual has to go see a pediatrician or a spine specialist because we might have a structural scoliosis here. And sometimes it's not, it might just be a non-structural scoliosis. But that being said, I was doing a little bit of research as to the schools in the US that actually do this screening, and only certain states mandate it. Not all states mandate this screening, which I feel personally is a little unfortunate because you could see here by the number being around 120,000 individuals being referred out for a follow-up, by a pediatrician or a physical therapist means that it would be helpful to catch this early on and say, hey, we don't have anything going on, which would be the best case scenario, or to say, yeah, we might want to investigate further to see if this is a structural scoliosis. So interestingly enough, 2/3 of those individuals that are diagnosed with structural scoliosis are assigned female at birth. Now, if the school nurse or the teacher detects the scoliosis, I think that it's going to be helpful for the pediatrician to then refer out to a different practitioner as well. Now moving on. What is the Schroth method? So what is this scoliosis specific PT treatment? I think it's helpful to understand the history because the type of treatment has changed over time, as things do. Katarina Schroth was the first to develop this method. She had scoliosis herself, so she actually developed this entire method and ended up having an incredible school where she had people come in. It's almost like a retreat of sorts. So they were there for weeks and they would daily come to class and in a studio space and work with her individually. And I'm sure individuals that were trained. And then she passed this method on to her daughter as well. So it has been disseminated quite largely. So we know this term Schroth method, but interestingly enough, with that dissemination, it gets distilled a bit. So the school in which I was trained in for this more scoliosis specific certification is called the Barcelona Scoliosis Physical Therapy School, the BSPTS. That was founded by Elena Salva, a physical therapist in Spain. She studied under Katarina Schroth, and also this type of method that they have in their schooling isn't Schroth itself. There are principles that they pull from. So it's a little bit conceptually and technically different than the Schroth method itself. It's important to know this in some ways because you may have certain practitioners that say they're Schroth certified. And it's not to get into the nitty gritty or the nuances, but I do find that it's helpful to get a sense of a practitioner's special certification if they have one, just getting a sense of where they have trained in that method. Now with that, I will say please don't confuse the difference between the scope of a physical therapist who may not have this certification, because just to really hone in on this, physical therapists are more than qualified to treat scoliosis even without this certification. I just really found it helpful to treat those, especially in the adolescent population, with a little different lens. And I feel like it's a little more specific for my own personal benefit in that way. So just to get the understanding of the history of it all and where it stems from is Katarina Schroth. So PSSE stands for, many an acronym, Physiotherapy Scoliosis Specific Exercises. So this is what falls under that BSPTS method and the technical differences that exist. So these exercises are not meant to correct or undo or decrease curvatures, but really they help to promote this optimal three-dimensional posture that's best for this person's body in front of you with scoliosis. It really is heavy on education. I will go through each session, especially that first initial evaluation, and sit down with somebody. It's a lot of me talking, but I end up incorporating visual aids, yoga blocks to sort of simulate the person's spine. I'll sit down if they have an x-ray and talk them through what the curvatures look like and what that means for their specific classification of a curvature. And we end up using that to then make the exercises be specific to their classification. These exercises do promote stabilization. So we're not just stretching and strengthening. There's a benefit to stability in our posture, and I find that that's the meat and potatoes or the special sauce of these PSSE. And interestingly enough, I want to hone in on the tactile and the verbal cueing. So when I first was introduced to this method in the training coursework, the instructor was so great with the verbal cueing, and how I noticed her crescendo and her volume of her voice really was impactful. It does change. So you'll hear a change in the volume of the cueing and the tactile cueing. I always get permission from folks before I end up touching, because we're really doing a lot of facilitation with our fingers and our hands to ensure that that person understands where to breathe into and where to facilitate that change in their posture. This all just wraps up nicely, these exercises, to enable the person to participate as fully as they can in their daily activities, whether that's bending forward to tie their shoes, something that seems simple but really can make a difference when they feel more stable, or reaching into cabinets, or being able to do the dishes for a certain amount of time. Like I may have mentioned this, typically adolescent idiopathic scoliosis is benign, or it's not as symptomatic at first. That isn't across the board, but that's what we find generally. So we may find that they're still able to fully participate at that age, which is wonderful, but there is adult onset scoliosis too, which we want to make sure those folks who are symptomatic in nature feel like they can participate wholly in their activities of daily living and in their desired sports and recreational activities. Now, what are we going to expect with physical therapy treatment, especially if there's a scoliosis specific lens to it? When I sit down with somebody for the first time and we're doing an initial evaluation together, I do typically ask if they've been to physical therapy before. It's just nice to sort of know what to expect. So hopefully this helps. You can share this with others so they're aware as to what they might be experiencing in the first few sessions. It's useful to have an orthopedic or a spine specialist write a physical therapy prescription. If somebody has structural scoliosis, idiopathic structural scoliosis, they may have seen a medical practitioner or a doctor beforehand. So that's usually sort of automated, that medical doctor will give them a prescription for PT. Radiographs or x-rays, I've mentioned, can be useful to actually make measurements. So we then take that x-ray, either the spine specialist and again the physical therapist too can utilize that x-ray and the measurements to classify what type of curvature pattern this person has unique to their body. And then we base that curvature and use that to implement the specific exercises that are best for their bodies, or their body rather. So the other thing that I'll hone in on with x-rays, deviating a little bit from the slide, especially when we're talking about individuals that are in the adolescent age group, we don't want to be exposing them to a ton of radiation. There is an EOS machine that exists, that is EOS, and it submits the individual to maybe 2 to 3 times less the radiation than a standard x-ray. And it's so helpful because it does the full view from the skull all the way down to the pelvis in front and side views. If you don't have an x-ray before you come in to see a physical therapist, that is not a big issue. We can still measure with a scoliometer, which is just a different instrument, and it tells us the rotation that you have in your trunk. So it's not the same thing as an x-ray, but we could still with our naked eye get a sense as to where your changes and rotations are in your vertebrae in your spine. That being said, it is helpful to have visualization of your torso. So if the person feels comfortable, I let them know the best attire to wear is a bathing suit top. Elastic waisted bottoms, we might have to roll them a bit at the waist to really see the tops of your pelvis, because that can be offset as well due to the bony change in the spine. And the hair can be up if it's long. We have you stand in front of a posture grid, and that gives us straight lines for you to stand in front of so that we could see the deviations that may or may not be present. And it's really insightful to see those changes over time, which is why we get your consent first to take photographs. But I think it's helpful for everybody involved, the person who's experiencing the symptoms and the practitioners, to see what changes may be happening. The number of sessions can totally vary. Generally, physical therapy is prescribed for 6 to 8 weeks. And I do find that diligence with the home exercises, the scoliosis specific exercises, important to do on a daily basis, but we always tailor it to the person's needs, whether that's lifestyle, activity level, and whether or not we can come in on a weekly basis. Videos are helpful. I've found that I'll take videos of the folks doing their exercises with my voice in the background. I try to work on my cinematography skills, because sometimes I'm shaking the video as I am talking and getting sidetracked. But really, we try to make it so this person has the best means to review and have this on their, and be able to do it on their own at home. Largely, again, it overlaps with the quality of life and the ability for this person to just maximize their participation in their activities. So that's what we're trying to achieve in this physical therapy sort of plan of care. So now we've gone through the major points. I want to kind of touch upon the large questions that I've found are largely common, rather. So is there a way to prevent scoliosis, has been something that I've been asked before, and I've read too on different forums. And if it's idiopathic, just to kind of circle back to the definition of unknown origin, and it's structural, meaning bony changes have occurred that we cannot reverse or change, then no, we can't prevent it. I think the other psychosocial or the emotional piece to this question is having heard and seen parents feel, and guardians, largely guilty that they didn't catch it. And remember again that it's a benign sort of presentation, especially at that adolescent age or even before. So there isn't some reason that you missed this. And I think, if anything, this really just speaks to the importance of spreading the word, of getting that simple screening done. If it's not done or mandated in your state school, then go to the nearest pediatrician's office, or having going to get a well visit done for that kiddo. That can be the best means to catch things early on if it's a structural scoliosis. Now, the other thing that kind of coincides with that would be, in terms of prevention, what is it that could make this worse? And when I say make it worse, I mean, what causes this? And again, we don't have a direct answer there in terms of the research. We know that there's a genetic component that could potentially be involved, hypermobility, but some folks will ask if it's their poor posture. They see their kids slouching a lot, and that's not part of it. That won't make it worse or cause scoliosis. The backpacks that they wear with the heavy back, the exorbitant amount of books, it won't cause scoliosis. It might cause discomfort, but that definitely will not cause this diagnosis. Will certain sports perpetuate it? Participating in school sports, participating in dance, participating in any sort of activity won't cause scoliosis. So these are misconceptions that I like to kind of address and make sure that people feel comfortable in sharing that as well, that these are not things that will cause scoliosis. And the other side of the age group here, which would be adults, it's helpful to note that this can come on in adulthood as well, just because of our, again, structural shape of our bones. If we have a predisposition, or we have osteopenia or osteoporosis, that is a weakening of the bones and the bone structure and the density. So that can lead to adult onset scoliosis as well, in which we, again, if we're certified in a scoliosis specific treatment method, then we can address that as well. We just are very cautious with bone density and making sure that we tailor the exercises to be safe on that person's body. Um, and lastly, this is not, I guess, a question so much as it is a PSA for, again, being careful with our words and being aware of the emotional piece that exists with this diagnosis because it is very appearance based. It's important to get somebody the help that they need and the team that might help foster that support. I just thought of bracing. Does my child, does my patient need a brace? Well, there are ranges in terms of degree of the curves that we use to dictate whether or not this individual would need a brace. That is typically done by a spine specialist or an orthopedic doctor. And that can coincide the bracing with the scoliosis specific PT. And it can help prevent progression of the curve. And again, that does parallel the emotional piece. This is hard for an adolescent aged person to have to wear a brace anywhere from 8 to 24 hours a day and feel a little bit confined in this plastic brace, or different materials exist for those things. But it's important to really have that conversation with the individual as to what that looks like in terms of their participation for sports, and being able to empathize and say, this is difficult. You are wearing something that probably makes you feel different, and asking them the right questions and listening, but also enforcing that importance of wearing the brace and not taking it off just because we don't want to have it on. So there is an importance in terms of wear time, but also just being sensitive to their needs and their emotional state in terms of having to wear this. So those are the major questions that I typically have heard, and hopefully this has been helpful for those who are newly diagnosed, for those who've had it and have been living with it, or those who just wanted a little bit of information to share and disseminate with others. I hope this has been helpful, and it's been lovely to be able to share this with you. I hope you have a really great day.